Hello and welcome to the World Shared Practice Forum. I'm Tracy Walbrink and I'm one of the pediatric intensivists at Boston Children's Hospital. Today we'll be speaking with Dr. Suchitra Ranjit. Dr. Ranjit is head of the Department of Emergency Medicine and Pediatric Intensive Care at Apollo Children's Hospital in Chennai, India. Suchitra, it's a pleasure to have you here today.
Thank you, Tracy.
Now, Suchitra, you're an expert in dengue, hemorrhagic fever, and shock. And I'm wondering if, for those of us who don't routinely see this condition in our intensive care units, if you might describe sort of a brief overview of what dengue fever and dengue hemorrhagic shock is and how these patients typically present to your intensive care unit.
Dengue is an interesting disease because prior to the 1970s, only about 9 countries had dengue, which was described in their patients. And is now epidemic in more than 100 countries. And almost 50% of the world's population is now at risk of dengue. And why is it that a disease that was confined to the tropics is now spread so much? It's basically all about dengue being a 20th and 21st century opportunist. And that's been facilitated by the extensive jet travel and the global population growth, the growth of cities, and sometimes it's happened in such a unplanned manner that there's overcrowding and ineffective vector control. Dengue is usually caused by one virus, of which there are 4 serotypes. So if you get an infection once in your lifetime, you are protected for the rest of your life from that one serotype, but you can get each of the other 3 serotypes. So it is a problem, especially because the second infection is much more severe always than the first. It's a very common condition in the tropics. Most children and adults would have just a bit of fever and muscle and bone pain. It's not a big deal, but a small proportion can get very unwell and need treatment in the hospital and sometimes in the ICU, basically because of a lot of plasma leak, and a few unfortunately have superimposed hemorrhage as well. So to answer your question, the immunopathogenesis is it's a huge cytokine storm that happens, and most of it happens after the fever has subsided, and that sometimes delays the diagnosis and recognition of dengue. So all the cytokine storm causes all the blood vessels to become really leaky, and plasma leaks out. So essentially the patient has hypovolemic shock. So the fever's down, they're in shock, but there's no external losses unless they've been vomiting. That's the hallmark of severe dengue. It's vascular permeability, but the losses are internal for the most part.
So that's really interesting. You know, it sounds like with this degree of capillary leak syndrome, it sounds quite similar to a lot of the conditions that we see in our ICU every day, from sepsis from bacterial or other viral etiologies. How do you distinguish this sort of cytokine release syndrome from dengue fever as compared to some of the other bacterial or viral conditions? And is that even important when you're treating patients with dengue?
That's a really important question, Tracy. And so that was, in fact, one of our early publications where we reckoned that both dengue and septic shock were infective conditions, both associated with capillary leak, and fluid resuscitation has been shown to save lives. We could as well apply the same septic shock ACCM-PALS algorithm to dengue shock. And we used the same ACCM guideline and compared outcomes to historical controls. At first glance, it seemed that we were doing really well, because what we did was we gave, just like septic shock, we gave rapid boluses of fluid until we reached about 40 to 60 mLs per kilogram, and then gave some colloid, used echo for serial filling. And then the patients who were in fluid overload, we used Lasix infusion or dialysis to remove the fluid. So we could demonstrate that the PICU mortality actually dropped from 16% to about 6.3%, which was a remarkable fall in mortality. So at first glance, it seemed that we were on the right track. But then we looked back, and it was strange that so many patients needed therapies to remove fluid after they were out of shock. And some of them were fairly invasive. We needed to pop in a peritoneal dialysis catheter. And these were patients at risk of bleeding complications. So we figured that maybe we've been giving a little too much fluids for dengue, and the two types of shock were probably distinct. At about the same time, this important paper from Bridget Wills came out in NEGM, where they gave just about 25 mils of per kilogram in 2 hours' time and preferred colloids for severe shock, and the mortality was just 0.2%. And this was in a center with not much of facilities of mechanical ventilation. So what was very obvious was that we needed to, septic shock seemed to require more fluid, and dengue shock lesser fluid. And in areas of the world where both of them would present to the emergency room, it was important to differentiate between the two. And we did a head-to-head comparison, a small study of 16 dengue versus 16 septic shock. And what was interesting was that dengue patients, the fever was down by the time they went to shock, whereas septic shock patients either were still febrile or hypothermic. The pulse pressure in septic shock tended to be a little wider, whereas dengue is a typically narrow pulse pressure shock. The fluid requirement was a lot more in sepsis, and the need for inotropes or vasopressor was also more. So, and of course, the hematocrits much higher in dengue. So these were the ways a clinician at the bedside in the emergency room could quickly make differentiation and not overload a patient with dengue who we need very slow, gradual, gentle filling.
So this is a good time to stop and ask our viewers to participate in the discussion. Please state your city and country location. The question is this: in your hospital, do you commonly treat patients with dengue shock, septic shock, or both? If so, briefly describe your approach to the management and monitoring of these patients. We're back now with Dr. Ranjit. So it sounds like if you can identify the patients and treat them early, they do better. But what happens when they actually make it to the ICU, these severe cases? What kind of strategies can you help sort of tell to the audience to help us improve the care of our dengue patients in our ICU?
Right. So the patients who need ICU care are the ones who have presented late. So the initial fluid is not sufficient to reverse the shock. And those are the patients are, it's not like the usual diarrhea and dehydration, the hypovolemic shock that pediatricians are being raised on, because there's no measurable loss unless they've been vomiting or hemorrhagic consequences. So it's hard to know the endpoints, and features of dehydration are absent. When you first look at a child with dengue, even before they get fluids, they're already looking bloated, they're already looking edematous, their lungs are wet, their liver is enlarged. So it's a bit scary to give more fluids to a patient who's already looking wet. And therefore, in a bit to have more objective kind of endpoints to fluid, and also the fact that it's so easy for them to come with hypovolemic shock, and in a few hours they are in fluid overload. It's a very smooth slide that can be imperceptible. So the objective endpoints would be obviously improved perfusion, so warm limbs, good capillary refill, and steady fall in the hematocrits. So the hematocrits gone up because the plasma's leaked out, and adequate urine output. So remember, at all times, we remind ourselves that we don't need to completely fill them up, just enough to achieve the lower range of euvolemia. So we aim for a urine output that's low normal. If a unit has people who are experienced at looking at the IVCs, that would be useful. We didn't have very good experiences with using a central venous pressure to have a gauge of circulating volume. But unfortunately, there's so much fluid in the lungs, in the belly, so there was competing pressure, pressures from all sides, and in most cases, it was falsely high, and that was impeding fluid resuscitation. And I think the most worrisome was the fact that insertion was actually dangerous, because once you hit the wrong vessel or puncture the vessel a couple of times, they bled and bled and bled, and that was not a very good consequence of a CVP. So we kind of concluded that a CVP had more risks than benefits, and it is being done less and less only when a child needed pressors or was really unwell, but with ultrasound guidance.
Mm-hmm.
And what was an even better low-tech CVP equivalent was a Foley catheter.
Mm.
So it worked in two ways. Urine output would tell us that the perfusion status had improved because the kidneys get the second largest blood flow in the body. And so if the child starts passing even 0.5 to 1 ml per kg per hour, it signals that hypovolemia is now better. And plus, a urine output more than 2 mils per kg per hour, which is generally considered normal, could be one of the earliest signs of hypervolemia. So that'll tell us that we better dial back the fluids. Of course, with a caveat that hyperglycemia and nobody sneaked in any diuretics along the way. So if there's if the blood sugar was normal, so it gave two important messages to us, that we controlled that we corrected hypovolemia, and also we could prevent hypervolemia.
Mm-hmm. Now, which fluids are you using to resuscitate these patients? Are you using colloids? Are you using crystalloids? What's kind of your fluid of choice?
Yes, so crystalloids work very well, and it's saved a lot of lives. It works very well, it's cheap, it's readily available. And the problem comes when children with severe shock need large, so the initial 20, and then the requirement is ongoing. You cannot dial down the fluid. So if there is 20, another 20, and maybe 10, 10, 10. So about 4 or 5 hours go by and you're still on large volumes and the urine output is just a trickle. So you're immediately worried that all that fluid is leaking out and going to cause, bad consequences of fluid in the wrong place. Mm-hmm. So at that point, we would think of using a colloid. Normally, when you think about albumin in a situation of capillary leak, the concern was that albumin would leak as well into the lungs and drag fluid with it, and in fact make a bad situation much, much worse. And that was the reason why many people hesitated to try albumin. But we did try albumin in children who we couldn't dial back the crystalloid infusion rates. And so we found that in most patients it really helped, and we could get the positive fluid balances down. But in a few patients, it seemed to hurt. And so you need to be really vigilant and monitor the when you use albumin to find out where it's helping. And these would be our endpoints, like obviously the perfusion should improve, the urine output should improve, the pulse pressure should widen as the hypovolemia was corrected, the hematocrit should come down, but importantly, the respiratory status shouldn't worsen, right?
Mm-hmm.
So I pulled out some case sheets where we used albumin, and you can see this was a child who was about 15 kilogram, and on the left hand side is the intake, and the child's getting 150 ml per hour going on for 1, 2, 3, 4 hours, and the urine output is just about 1 ml per kilogram per hour. It's not too bad, but she's getting more and more positive. She's already got about 600 ml and passed only about 60 ml, and then urine dropped further to about 5 ml. And somewhere here we started albumin, and you can see here the urine's picked up quite briskly and continued to have, continued to flow even after we stopped the albumin. And out here is a blood pressure charting. So the pulse pressure is a little narrow here, but after starting albumin, it widens out nicely. So this corresponded to the improvement in in the urine output and the fall in hematocrit. So we did have pretty good results, but and that's why we want to study it more rigorously. But it's important to remember that once you started, the whole unit must be aware that we're starting a drug that does help, but it can hurt in a small minority, and we must stop quickly in those children.
Mm-hmm. We'd like to take a moment now to involve our viewers in the discussion by asking a question. In your response, please state your city and country location. The question is this: in your PICU, for patients with dengue shock, do you typically resuscitate with crystalloid or colloid? How does this compare to your fluid choice in resuscitating patients with septic shock? And now we're back with Dr. Ranjit. Well, what about inotropes? When do you ever sort of need to use inotropes when you're managing these patients? And if so, what would be the trigger that you might use to pull when you want to use inotropes for these patients?
Right. So there's a slight deviation from patients with septic shock, especially in relation to inotropes. So in septic shock, if they are fluid refractory, you would think about inotropes. But in dengue shock, if they are refractory to crystalloid or colloid, the most important thing to remember is that they might have occult blood loss, usually in the gut. So it may take a while before it comes out from the lower end. So if shock is persisting despite appropriate fluids and the hematocrit is not looking almost normalish, think about blood loss. And at that point, giving them whole blood, it's simply the best kind of product that you can do for this patient. But it may not be very easy to get. In that case, you might need to give packed red blood cells. But certainly some patients with dengue can have myocarditis, although it's not very frequent. Some degree of myocardial dysfunction can occur from prolonged shock. So it's an ischemic kind of decreased coronary perfusion and ischemic myocarditis. So be that as it may, some patients whom you adequately fluid resuscitated and given them blood as necessary, if they're still in shock, you would need inotrope. And it's just that if the blood pressure is really low, we would give them epinephrine and otherwise dobutamine, right? So it's basically an inotrope, either an inopressor or inodilator, depending on the blood pressure.
And when do you start thinking about hemorrhage?
That's a good question. When do you suspect bleeding? Obviously, if there's external bleeds and the child's been throwing up blood, it's easy. But sometimes it can be an occult bleed. And if we give more and more RBC-free fluid at this point in time, that can cause a very abrupt deterioration in their overall condition. So it's important to think of it early if they are still in shock after 30 or 40 ml per kilogram. I think it's really important to think of bleeds. And the clue might be that generally if it's just plasma leak, if it's all plasma leak, the hematocrit is going to be really, really high. But if it's plasma leak and RBC loss, the hematocrit, which was high, rather being really low, will be somewhere in mid-range. So a normalish hematocrit in the presence of low blood pressure should lead one to think of hemorrhage. And or if you've already given fluids and the blood pressure and the hematocrit falls inappropriately, think about bleeds. And the other clues might be a persistent metabolic acidosis, high lactates, severe abdominal pain, especially if the child's bled in the gut, and a very lethargic or restless patient. So I have this little bit of pictorial representation of what happens to the hematocrit. And if a patient so that's how the child starts off before he or she started leaking. So the hematocrit, say about 36, right? So when there's plasma loss and the compartments narrow, the hematocrit goes up purely as a hemoconcentration. If there's plasma loss and blood loss, you'd almost reach the pre-illness hematocrit of 36. And when there's excessive blood loss, it's only then that the hematocrit starts to fall. So the difference is that the degree of shock is much, much worse. So when they've lost plasma and they've bled, the degree of shock is extremely profound, right? So correlating the clinical features of shock with hematocrit can give one a pretty good idea of whether they've bled, and then there's a real urgency to get the RBC in pretty quickly, because that's the single therapy that will save that patient.
Now you're describing how important the hematocrit is to sort of follow and trend. What is your management strategy in terms of monitoring? What are the labs that you find important to send, and how often are you tracking them? Obviously, the more labs you send, oftentimes the delay of coming back and where you are compared to what you're treating, and where your treatment pattern has gone. So what do you do? Do you have a standard protocol that you follow? Is it more tailored to an individual patient?
Yes, Tracy. So to answer your question about what kind of lab parameters we monitor, not a whole lot of lab parameters except a serial hematocrit. And in some hospitals, they have a little machine at the bedside where you can take a few drops of from the patient and you have the result back immediately. So it's really the hematocrit, and maybe if they are very acidotic, you would follow blood gases. But essentially it is point of care kind of monitoring. And as I said earlier, we are fixated with the urine output, and even the nurses are pretty tuned, and they note down the target urine for each patient and let us know if it's less or more than expected. So that is a very useful kind of low-tech and effective monitoring tool. So we do hematocrit, and if it's like 50 or 60 and it gradually comes down with fluids, we know we're on the right track. It can get a bit messy when they start bleeding. So a sudden fall may indicate either you're overhydrating them or they've bled, right? So we had to correlate with the clinical situation. A serial echo we have done for fluid titration, but then you need people with expertise. And the IVs, the inferior vena cava, can be compressed simply from all the fluid in the belly. So Not always useful, but if you can do, it just gives additional information. Clinical examination is good to detect shock, but not so good to follow because of all the cytokines that's storming around in the body. Their extremity perfusion may not be a good indicator of what's going on with their perfusion. So CVP, as I said earlier, it's not useful at all. And certainly looking at their their respiratory status and liver size may not be useful. So it boils down to just clinical examination, urine output, and a hematocrit, and blood gases once in a way.
Once again, we'd like to turn to our viewers to ask a question. In your response, please state your city and country location. The question is this: where you practice, what types of monitoring strategies have you found to be most helpful in monitoring the evolution of hypovolemic or dengue shock? And now we'll return to the conversation with Dr. Ranjit. Now, you mentioned earlier, about some of these patients that do get fluid overloaded and that many of these patients have wet lungs. What proportion of these sick patients actually require invasive mechanical ventilation and support? And are there any specific considerations upon induction or anything that you worry about when you actually do have to intubate and mechanically ventilate these patients?
Right. If you think about what's being taught to in the emergency room and critical care units, you tell your fellows to intubate early when patients have breathing difficulty and shock, especially when they have both. But in dengue, some patients can deteriorate very badly after we give them drugs for induction and place them on positive pressure ventilation. I think the whole deal is because they're already in hypovolemic shock, and the positive pressure decreases the preload quite dramatically, and they can suddenly get a lot worse when that spontaneous respiratory drive is abolished with drugs. And now we've learned that to delay ventilation, intubation as far as possible. So in my mind, dengue comes right up there with say asthma or DKA, where you'd want to delay intubation. And if their lungs are really bad and they're very hypoxemic, we would give them a brief trial of non-invasive CPAP, where their spontaneous drive is still maintained and their preload is not blunted in any way. Quite apart from the whole problem during intubation, even after they're placed on positive pressure ventilation, the ventilation worsens shock. Once shock is worse, you get even more fluids, and then the wet lungs worsen, the belly gets tighter, so hypoxemia worsens, the airway pressure goes up. So it's a pretty bad cycle, and best avoided rather than treated.
Now, how long is the natural course of this disease?
That's the beauty of dengue. It's a huge storm when it lasts just after the fever's down, but it's just 24 to 48 hours that they're in the eye of the storm. So while some children do get by with CPAP positive pressure for about 8 to 10 hours, a few may need a longer period. But to answer your question, it's about 24 to 48 hours that they are really unwell. And they can look as if every organ has failed and they're desperately fighting for their lives. But it's really worthwhile trying every effort to save them, because after the period of the so-called critical period, they improve very, very rapidly. And there's hardly any sequelae in terms of limb loss or organ failure or neurological deficits. In fact, they're discharged once you're better in a week or so, and another week they're ready to go back to school and nobody can tell the difference.
Wow.
So it's really worthwhile. So your very well-nourished children get extremely unwell and bounce back to their former well situation. So,
which I think I now understand why you are so focused on the fluid overload problem.
Right.
This is a time-limited problem, and if I would imagine if you give a lot of fluids early on, they end up staying in the hospital for longer to try to get that fluid off. Is that?
Sure. Even the short critical period is now extended, and they need more therapies to remove fluid. Yeah.
So as we were talking about earlier, the WHO classification has changed. And I was wondering if you could speak a little bit to sort of the concepts of why the change was necessary and what the new classification scheme looks like.
Right. So the old classification worked for many, many years in many countries. And there were many research papers based on the former WHO classification. It had 4 grades, and the grade 1 and grade 2 was more based on the tourniquet test, where a blood pressure cuff was tied on the upper arm, and the number of petechial spots were counted. And grade 2 was more spontaneous bleeding. And grade 3 and grade 4 were children who actually had shock. And so the difference was grade 4 were the sickest with an unrecordable blood pressure. And there was also platelet count of under 1 lakh was also a criteria. But then people found that that the workers dealing with dengue were getting a little fixated with the platelet count, which in some children were maintained even when they were in shock. So there was a move towards getting a classification that not only de-emphasized the platelet count, but also could preempt the critical stage by describing warning signs. So there are some warning signs that a patient with dengue is going to go into a sick critical period. So the current classification, which came out in 2009, it's just got 2 main limbs. So there's dengue with no warning signs and dengue with warning signs. So dengue with no warning signs would be just children who have a bit of fever and feel unwell, but otherwise breeze through. Warning signs are those with, so especially abdominal pain and vomiting. So it alerts the caretaker that this particular patient may have problems. So you would not send such a child home. So there's dengue and severe dengue with children who have shock, respiratory symptoms, severe hemorrhage, and any kind of organ failure, right? So organ failure wasn't a part of the previous classification. So liver, kidney, encephalopathy, any organ failure was severe, right? Rapid fall in the platelet count, all of those came in severe dengue. I have this slide of this is a beautiful slide that's actually was put forward by WHO. Have a pictorial representation of each phase with what happens. So initially there's fever, so there's pretty high grade fever with no clear focus. And after the fever comes down on day 3 or day 4 is when a small proportion of children get into strife with a lot of lung fluid, shock or bleeding. And that's a time that if you look at the labs, the hematocrit's starting to rise and the platelets are starting to fall. So there's a lot of things that happen together, and once the clinician can recognize that all these things are happening, we can quickly get our act together, get some fluids on board. And so after that 24 to 48 hours of the critical phase is a recovery phase. Most children do very well, but a few of them can have lung issues as well, because when all that fluid comes back to the vascular compartment, they can go back into pulmonary edema.
Well, thank you for this wonderful overview of dengue and how these really critically ill patients with dengue present in the ICU and are managed. I wonder if I could ask you, as an expert in dengue, what do you think are some of the future strategies that we don't know, that we need to explore and do more research on? Where's the field going?
Right. So what was really curious for me as a clinician was to see how these really well-grown, well-nourished children fared so much worse than the little malnourished rats who kind of breezed through. So it would be nice to know what's happening from the immunological front and what exactly is the nature of the cytokine storm. People have done research in this area, but it would be really nice if you could pinpoint the key ones and find ways to block or neutralize those cytokines and nip the whole storm before it got out of control. So that was one, and as a caretaker and clinician, I'd like to know when they present in the emergency room, because 2 children who come at 10 o'clock in the morning with similar kind of features of shock and hematocrit and platelet level, one would be fighting for his life by evening, and one is almost ambulant and just taking a bit of extra oral fluid. So it'd be nice to know if there was a way to predict which are the sicker patients, because we could triage them and focus our attention on them. So that would be great as a futuristic thought.
Fantastic. I wonder if you wanted to just leave your last words of wisdom. What are the key things and key take-home pearls that you want all of our viewers to sort of take home from your presentation today?
Right. It would have to be prevention.
Mm-hmm.
Right. So it's not a new disease. It's been around for years, and we know that with the monsoon, with the rains, dengue is the next inevitable consequence. So I guess if the public health and the other health workers, doctors, nurses, everybody involved would focus on prevention, on education, and controlling sites for mosquito breeding. And after all, it occurs every year, so we should be getting better and better at it. And so prevention, and also widespread dissemination about the early features of dengue, so that we could catch them early, just give them some extra oral fluids, and not have them come into the ICUs fighting for their lives.
Oh, wonderful. Well, thank you so much for this absolutely fantastic overview. I'm sure that our audience has gleaned a lot of important and valuable information from your talk, and some real teaching points on how to manage these patients, because I worry with all of the travel that I might see a patient that has dengue fever in my ICU at some point. And now I think you've given us some really great strategies and things to think about. So thank you very much.
Thanks very much, Tracy.
If any of our audience has any additional questions for Dr. Ranjit, please leave them in the comment section. Thank you.